As my previous speaker has said, I think that the clinical definition of sepsis today that was revised and published in JAMA in 2016 contains one important concept. Sepsis is a complete derangement of the immune system. There is an immunodysregulation, whether you have sepsis or septic shock, that is associated with high hospital mortality. Now, sepsis is a cascade. It starts with the bacterial invasion with the host, and then LPS is disseminated in blood, of course recognized by monocyte through CD14 receptors, and then leading to endothelial activation. And then you have a humoral cascade and cellular cascade that leads to defects in microcirculation and finally organ failure. I think that if one look at sepsis with the same approach that we used for uremia several years ago, we can describe the serum of septic patient as a serum that contains a lot of retention molecules that may be present in different concentration, but especially they are present in different concentration in different moment of the syndrome. So a conceptual continuum for an approach to septic patient, in my view, should start from source control, as Marlies has suggested before, possibly endotoxin removal, but this is only the first part. Subsequently, when the immune dysregulation occurs, immunomodulation and cytokine removal may be the subsequent step. And finally, when organ damage occurs, you need to support organ function in order to get the patient out of the ICU and possibly out of the hospital, surviving, of course. The truth is that every single step has a specific time window, and probably the endpoint for each approach is different. Because at the beginning, we just have to keep the patient alive, while subsequently we have to give space for new therapies and other approaches. We definitely know that endotoxin and mortality are interconnected, and if you have high endotoxin level in blood, mortality is generally higher in septic patients. We also know today that we have devices, as Thomas has presented, that through hemoperfusion mechanism associated with CRT or not, can actually provide absorption and removal of endotoxin. Endotoxin can also be removed by system that, like the auxiliary membrane, can actually provide the simultaneous renal replacement therapy. So whether you use a sorbent bed or you use a membrane, there is evidence today that a great amount of endotoxin can be removed from the blood, both in vivo and in vitro. In the past, we have done a meta-analysis, and we have analyzed several different papers using polymyxin B hemoperfusion, and we found that there was a strong signal in favor of using polymyxin B. In particular, I like you to point out that the control group had a mortality rate in the range of 60%. And therefore, the reduction observed in the treated group of 33.5% was quite significant. We did also a prospective randomized control trial that was not originally designed to achieve results on survival. It was designed to achieve information on what is occurring at 72 hours in terms of organ failure and SOFA score. And it met the results in terms of improvement of organ function, but also we surprisingly found a signal with improved survival in patients with abdominal septic shock, mostly post-surgical. interestingly enough, the results were close to the results achieved in the meta-analysis. At this point, my friend John Kellum wrote a nice editorial and said, fine, we love this result, but we need more evidence. And I would say that America and Europe took two different directions. One was Europe decided to go for pragmatic trial, one retrospective phase, one prospective phase, a registry data collection. US moved to a randomized control blind trial on use of polymyxin B. In our own study, what we found was that those patients in the registry that had the same characteristic of the UFAS trial displayed exactly the same benefit in terms of survival, while the other patients did not. This was a typical observation that probably the therapy is not a generalized therapy for the overall population. We should actually indicate exactly who is the patient that most benefit that therapy. The other paper, the Euphrates trial, which is unique for certain reasons because it is, just think it is a blinded study. So the centers had to blind and make a sham extracorporeal circulation. I think it was just a fantastic setting that must have costed a fortune. Did not meet the primary endpoint. However, there is a kind of a signal, kind of 5% difference in favor of the treatment, but not statistically significant. However, the number of patients in the study makes me suspicious about the fact that the study may be underpowered. There is another issue related to this, and this is the fact that endotoxin assay is a linear, let's say, efficiency in the measurement when you are between 0.5 and 0.9 or 0.6 and 0.9, while after 0.9 you may have a very high concentration of endotoxin and the function is not linear anymore. And in the population treated, almost 20% had an endotoxin assay higher than 0.9, showing that they might have been whatever. We don't actually know. So if you actually take only the patient modified per protocol in the population that are between 0.6 and 0.9, there is a strong signal in favor of survival, and there is a strong signal in favor of improving hemodynamics and improving mechanical ventilation-free days. So if I have to summarize the use of this sorbent in sepsis, I may say that several trials in the past using drugs had simply wrong targets. We use Centoxin, antibodies against endotoxin. The target was correct, but the method was wrong. UFAS, right target, right method, right population, probably small size. Euphrates, we're not sure that that was the right population, but we are sure that maybe there was also a small size. And finally, the UFAS-2 is a typical pragmatic trial that offers you information on what is occurring in the field. Basically, if you analyze a general population, you may have patients that tend to die whatever happened because they are too sick. On the other hand, you have patients that tend to survive in spite of our intensive care physicians because they are not sick at all. But in between, your intervention can actually make a big difference. And this is the logic and the rationale for the application of precision medicine. So endotoxin assay and measurement and correct measurement of endotoxin can actually trigger the intervention in the right population so that we do not have adverse, no effect, or some effects. We can have beneficial effects. The other thing is that we might have other mechanisms involved in the use of adsorbents, like removal, for example, of activated monocytes, as it has been demonstrated in this paper. Again, sepsis, it is not only an hyperinflammatory state. There are certainly patients that die because of intractable inflammation. But we know that there are also patients that tend to die because of late persistent immunosuppression and immunoparalysis. So the problem is we have no way to monitor where the patient status is. Maybe in the very first phase, we need anti-TNF, later on anti-IL-1, and then later on anti-IL-10 because the patient is in the immunodepressive state. So blood purification actually systems cover probably all the different phases, and the idea is to provide immunological support. Thomas Rimelet has presented all these different techniques, how they have somehow provided some evidence, but little evidence, enough, however, not to discard their use. Highly absorptive membranes seems to be important. PMMA or Oxiris, they have different characteristics and they can actually remove a significant amount of cytokines and endotoxin. This is PMMA and this is Oxiris. So if you have an important effect on cytokine clearance and demonstration that adsorption is an important phase, maybe adsorption should be further utilized. And this is how it is in the case of coupled plasma filtration adsorption. What we have found in a study some time ago was that not only we found an improvement in hemodynamics and the requirement of vasopressor support, but we also found that the cell of septic patient started to respond again when incubated with LPS with better TNF expression and better phagocytosis. So the immunoparalyzed cell started to work again. And the other thing we have seen using sorbents in the CPFA was that the immune system that was paralyzed and unable to present the antigen, and this was demonstrated by a depression of HLA-DR expression, started to improve this capacity over time. So after the endotoxin removal, we have the possibility to remove cytokines with different columns. You see, we have different columns. I'm not just proposing one instead of the other. I'm just saying that we have different methods. And we have tested, for example, recently the different columns from Jaffron. And we were somehow worried about biocompatibility because we want to remove cytokines, but also we don't want to generate any adverse effect. And what we found was absolutely no difference, both in static and dynamic condition, in terms of cell viability when incubated with this. For example, we treated some patients with CVVH plus hemoperfusion, and we have seen that we might have different indications for these different columns. Recently, removal of humoral mediators have been demonstrated by this different microporous raising column. You can see, for example, the removal of IL-1, TNF-alpha, and other different types of columns. The use of Cytosorb has been advocated, utilized alone or in combination with the CRRT. You can place the cartridge before or after. We have tested this device in different conditions. John Kellum has demonstrated great potential for removal of different cytokines. Recently, papers have been published showing significant reduction of IL-6. So there is actually a large capacity, and there is now a registry for these different treatments that show that cytokines and cytokine storm can be actually counterbalanced by this use. And I think the registry can actually offer some information. So where are we? I think that our proposal in the past was that being aspecific, either removal by CRT or by adsorption, can actually cut the peaks of pro and anti-inflammatory mediators. It doesn't matter where you are. And it doesn't matter if there is a simultaneous hyperactivation or immunodepression. You actually restore a little level of immunohomeostasis. The problem that we have is that if we knew by some biomarkers that the patient is in this status, maybe he needs corticosteroids, maybe he needs antibiotics, maybe he needs different drugs, but laboratory medicine is not fast enough in this case to tell us where the patient is. You know that we had different hypotheses, the threshold immunomodulation hypothesis that suggests the transport from the tissue into the bloodstream when you have a kind of removal by extracorporeal therapies, blocking also the production. The mediator delivery hypothesis is what defined the so-called tissue flow tsunami. We remove from tissues by removing from the blood and creating a new equilibrium. So my idea is that today we have also the possibility to support organ when organs fail after the endotoxin storm, after the cytokine storm, when organ failure occur. And at that point, we know that if we have multiple organ dysfunction, we have actually multiple organ system therapies, extracorporeal organ support. We have from ultrafiltration to CVVH, plasma filtration, hemoperfusion, albumin dialysis, CPFA, ECMO, VV and VA ECMO, and ECHO. At this point, we can support different organs. So how can we envisage a correct therapy for sepsis? I think what we need to do is an integrated approach. And the integrated approach is in the phase of infection and bacterial invasion and LPS delivery, we need to remove endotoxin and have source control. In the moment of immunoderangement, we may battle the cytokine storm. And in the moment of organ damage, we actually might need organ support. So my future of intervention is a kind of integrated and sequential approach, starting with pharmacological, timely endotoxin removal, immunomodulation with extracorporeal therapies, adequate organ support, condition favoring organ recovery. So a kind of personalized therapy, which is not only personalized per single individual, but per single moment of the pathological life of that patient, what I call precision sequential extracorporeal therapy. We need to identify the population. We need to have precise targets. We need to have this because we need to control if the therapy claim some action and obtain this action. In this case, we cannot say that the therapy has failed because the patient died. We have to move to the second step. Identify endpoints for clinical studies. Adopt dynamic prescription criteria. What do I mean? If you see endotoxin climbing, that's the moment to apply extracorporeal removal of endotoxin. Use biomarker-driven precision therapies and use sequential therapy. So at the end, I think that randomized controlled trials have to be designed, if we do randomized controlled trials, with precise endpoint. Otherwise, we have the risk that we throw the baby with the baby wash. Thank you very much.